Hello, peoples. Let's see your faces real quick. Good to see Jimmy. Jimmy Faracci. That's my bad Italian accent. Mike West just got up. He's got that look to his hair. See this? I just got up too. Makes no difference. Ariana, that same seat. Okay. So Bezowit, it's funny. You know your friend, what's her name? Bimalak? She's she's back in Ethiopia. Is it Ethiopia?
Yeah.
So when she went back to Ethiopia early in the semester, I thought it was you because your names are so similar and you always sat right next to each other. So like for most of the semester, I think she's coming in from
Oh,
Ethiopia. And I'm like, well,
no. And
wait,
also,
no.
there's another Bamlak. There are two of them. The one that always sits beside me, like the one that you know,
Okay, yeah,
and
yeah.
there's another one that came a semester later than us.
Oh, okay,
That
okay.
that one is in Ethiopia, yeah.
Is that a common name?
Yes.
Okay, okay. So we've got Perky Gogo coming today. He should be here at about 9:40. I got a text from him. He's having trouble. He usually works at UVM, but I guess he also works up at St. Albans Medical Center, and he's up there, and their Wi-Fi is down. So he's going to try and come in on his phone. We'll see how that works. But I'm hoping it works because I've got nothing else to talk about today. Let me share. Oops. Here's one thing he's going to talk about, something I left out on Thursday under coronary artery disease, preventative things, anti-clot medications. So I didn't even talk about these. I totally forgot about them. He's going to talk about them today. And let's see. Also, I believe he's going to talk about pop music. Talk about angioplasty, stents, and bypass. He does some of this, but he's also going to be talking about drugs for this kind of stuff. So I think he deals with a lot of coronary artery disease. And I told him we didn't cover congestive heart failure yet. So if he wants to cover that, he can. Anything that gets me out of doing work, if you know what I mean. What? Did I say that out loud? Okay, coronary artery disease. James.
Would you be able to post this lecture? Because the actual PowerPoint's not up, and I like taking notes right on it.
Let's do this now.
Okay, thank you.
I forgot it was there. I mean, I thought it was there. I just forgot to put it up.
No worries. Just
doing it now because if not, it'll be out of my head. As you know, my head is a sieve. Things just filter right through it. I hate to say this, James, but you're right. It kills me to have to say that.
I know it. Once in a blue moon. Once in a blue moon.
Okay, so it is up. Almost up. And there we are. Just cleaning up house a little bit here. And we're back. Okay. So we're just waiting for Perky. Anybody have any questions while we're waiting? So our exam is next Tuesday, right? So Thursday, I'm going to talk about congestive heart failure and maybe arrhythmias. We'll see. See what I want to get into at that point. And that'll be about it. So then after that, I need to this week I'm going to get up a Google Sheets so you can sign up to make a presentation too. And I'm going to look up some papers that would be good for you if you want examples or what am I trying to say? English, Don, English. Oh, you can choose your own paper, or you can take one of my papers if you want. So we'll talk about that. I mean, I'll send you an email on that. Is anyone else getting tired of this semester? Or is it just me? This is a lot more work, at least at my end. It's a lot more work doing it online like this. I don't have to drive to work, which is nice. That saves me 2.5 hours a day, but still, it's like, yeesh, this is a lot of work. I think next semester is going to be easy for me because I'm doing cell biology, which is almost totally online. Well, it's half online anyway. And developmental biology, which is also half online. So next semester, I don't know. I guess I'm going to, I don't know, have more fun. Less work, more fun. More money, more money, more money. Another nice thing about, well, a good thing about this is so much work doing it, but I think I can start offering these classes online and then we're talking more money. Yeah, yeah, baby. I might make another $50 on that. I'm going to text Perky. I'll give him a couple more minutes. And then I'll text him to make sure he's okay.
He stopped by actually. And I was at 9:22. He said, "See you in a half hour." So.
Oh, good. Oh, that would be 10 too. That might be another 10 minutes. Yeah. So, do you guys have any questions? Maybe I can ask you some questions. Let's see. Here's a good question. Why are nitrates good for angina pectoris? Sublingual nitroglycerin for angina. What's the mechanism? How does it work? Nobody knows? Nobody knows. Oh my God. I thought you guys were like sitting on the edge of your seat, like just taking all these pearls of wisdom coming from my mouth, but it's like, test is next week. I don't care. Nobody knows? And nitrates. Okay, let's slow down. Nitrates. How do nitrates work? What do they do? Cellularly. Cellular. Good.
Isn't it involved in it like gets turned into nitric oxide, which opens up the veins. Oh man.
You're right.
Yeah. No, there's something else to that. Yeah.
That's all.
Okay.
That's all I was looking for. Yeah, it produces nitric oxide inside the smooth muscle and relaxes the veins, more so veins than arteries. Okay, question 2, Biscuit. How is relaxing the veins going to make angina pectoris better? Okay, let me step back and ask the first question. Did you just give me the finger? I swear. You went like this. You looked like you went like this. I'm like, I just asked her a question. No, wait. No. Before you answer that, let me back up and ask one a lead up question. What causes the pain in angina pectoris? Just pain.
Is it decrease in blood into the heart? So it has.
Yep.
No, just disregard what I said.
No, you're right. You've got coronary artery disease, so you're getting less blood to the ventricle. There's Perky. Hello, Perky.
Hola, ¿qué tal? Can you hear me?
Yes. You can do it.
Oh, perfect.
You want half these people speak Spanish.
Oh, I don't speak Spanish.
Oh, okay.
I speak un poco. That's it. Sorry,
Okay. That's
my
all.
camera is not. It's not secured. Apologize for this.
More. Un
I'm
cerveza, por favor. ¿Dónde está los Dios?
All right, here we go.
Okay, so
So-
Perky, let me just introduce you a little bit. Perky is a friend of mine. His son is in the same class as mine in middle school, and we hang out together. We do cultural things together. We go to concerts and art openings and things. So he's a cardiologist at UVM, but also Albany Medical Center, or not Albany, St. Albans. You're up there today.
Yep. Mm-hmm. Just about 20 miles from you guys on the other side of the lake. So.
There you go. All right, go ahead, Perk.
Right. So Don just kind of gave me free reign to talk about whatever I want to. So we're going to talk about politics for the next 10 minutes. I'm joking. Anyway, we're going to actually talk a little bit about the stuff you're learning and how important it is to the stuff that I do in terms of, a whole panoply of cardiovascular procedures, the treatment of heart disease, that kind of thing. So what I want to do is walk you through not only some of the basic disease processes that we talk about, that we take care of, but also some of the procedural stuff we use to treat this. Now, as you can imagine, advanced in a significant way in the last 30 years or so. So you can go back to even 40 or 50 years ago, we barely even knew what a heart attack was. Okay, so this whole idea that plaque buildup and clotting in an artery causes major damage to our heart muscle is only about a concept that's only truly about 65 years old. The ability to do something about it other than pharmaceuticals in terms of procedural stuff is only about 45 years old. When you're talking about bypass surgery, that goes back to the 1970s. And then the stuff that I do includes stenting of arteries that have blockages in them. That's only from around 1982 or so is when we started doing it in Vermont. We got stents in 1992. And then in the last 10 years or so, we've expanded all of this stuff into treating even valvular disease without surgery. So if you have a heart valve, that your heart valve is either too leaky or it's not opening up wide enough, we can now replace those valves via catheters about this wide, stuck through your femoral artery all the way out to your heart, and replace the valve or repair it in some way without having to do an open chest surgery. So that's the progression of the technology of heart disease, but it really goes way back to basics in terms of the disease process, how we're approaching it, how pharmaceuticals actually make the procedures that we do safer. So you can imagine that if we stick a foreign object into your body, the thing that your body wants to do is get rid of it, right? So in some way. So if I put a piece of metal into your bloodstream, your clotting system is going to want to attack it as soon as possible. And any kind of foreign object placed into the bloodstream can be a nidus for the production of thrombus. And so what I was going to go briefly over once we talk about some of the procedures we do is some of the medications that we use in the cath lab every day to reduce the likelihood of clotting or a brief whatever. So anyway, demonstration aid here. And so hopefully you can see this. Maybe not. Maybe I'll have to go. Oh, there's reflection. Yeah, that's too much. Hold on. Let me get rid of this light. Ha! Okay. So right here, our artery. This is good. Oh, there we go. So those are the arteries of the heart. All right. So that's the basic pathophysiology of what a heart attack is. You can imagine that the heart is a hollow muscle. All it does is it pumps blood out to the rest of the body. The arteries themselves and the blood the heart can't use the blood that's inside the chambers of the heart for its own purposes. So it has these tiny little arteries that are only about 1/4 inch in diameter, maybe 3 or 4 millimeters in diameter, supply blood to the heart muscle. And it doesn't take very much volume of either plaque or thrombus to occlude any of those arteries. So let me just bring up something else. So let's go through the atherosclerotic process here. So this is atherosclerosis. Okay, hopefully this will come in. Yeah, there we go. And so it'll go over and over again, but you can see here that I'll go back and let it start over again. Okay. Or maybe, well, let's try this again. So that's your normal artery, meaning that there's an area in the wall of the there's an area where the blood flows. That's all the red dots. Those are red blood cells, and then that's encapsulated by walls of the artery that are mostly smooth muscle and smooth muscle and connective tissue. The atherosclerotic process is that, and unfortunately, this may be the status of Don and my arteries right now because we're old people now. So as we get old, plaque can build up in the walls of that artery and start to encroach on the flow of blood in the middle of that artery.
Say it ain't so. Isn't part of your job lying to your patients?
Only to make them feel better. So anyway, as we get closer here, this is where stents start to come in, right? So this is it really physiologically takes a 70 to 90% narrowing of your artery from cross-sectional area in order to diminish the blood flow that already caused problems. What happens is when the blood flow is diminished downstream from that blockage, your heart starves of oxygen, and it can send either neurological signals of pain. It may also become dysfunctional if the starvation of oxygen is severe enough to the point where that heart muscle becomes weak and doesn't contract very well. If it gets to the point of right here, if you see, let this focus in, that on the right there, there's a little rupture of the plaque. So this is the theory, the modern theory of why heart attacks happen. You can see that little thing, that little piece of the wall that's lifted up. So what we think is that the atherosclerosis in the wall of the artery, what happens is when it builds up, it becomes very inflamed. That all that yellowish stuff is actually, some of it could be liquid cholesterol, liquid fat in the wall of the artery. And there's also a lot of inflammatory cells in there. And what happens is the cap on top of this stuff, walling itself off from the flow of blood in the artery happens. Unfortunately, that rupture can volume of clot to completely just stop up the entire artery, and then everything downstream from that starts to get irreversible damage the longer that artery is obstructed. Okay, so that's really what that's my bread and butter. That's what I do most of the time with my work. Oh wow, you can zoom these things in too. I had no idea. Okay, so let me just show you this stenting interactive. Okay, so here's what we do with stents. All right, so what we got here is a narrowed artery, and what we have is a wire. See that little wire going through the artery? That wire is about the width of a human hair, and it's a meter long. Those are the wires we use to place into the artery. Once we get that, we bring a balloon catheter down there, and once that's there, we expand that, and that stretches out the artery. So that's basically angioplasty right there. The problem with balloons before is that once you deflate the balloon, you can see how the artery walls rebounded, right? So they rebounded, and that elasticity, unfortunately, can cause a low threshold to have a reblockage very soon after the balloon. So what we do nowadays is we bring in a stent, which is basically a piece of metal mounted on top of that balloon, and we expand that, all right? So that's expanded. The balloon is expanded and then deflated, but the stent itself is left in place. And it's a scaffolding that prevents that elastic recoil of the atherosclerosis from encroaching on the blood flow, okay? And so UVM, which is, I'm the director of our cath lab at UVM, and we do over 1,300 stent procedures per year, and the average stent procedure we do about 1.8 stents per procedure, so we use several thousand of these stents per year. The thing about these stents now is the technology has changed so much that that even the stent itself has a pharmaceutical on it. All right, so what happens is that artery that's been stretched out, a lot of times scar tissue can go right through the stents and reblock the artery within 6 months. So before 2003, this happened about 20 to 30% of the time. But what the manufacturer started doing is putting anti-proliferative drug usually analogs of sirolimus or FK506, which is usually used in transplant medicine. But this anti-proliferative drug prevents that scar tissue from encroaching back into the through the stent struts and reclosing that artery. So pretty much almost all the stents today have a drug coating on the outside of them. And the way it was fascinating about these devices is they're so meticulously manufactured. The companies can actually determine how fast the drug is eluted off the coating of the stent. So some drug manufacturers are strongly opinionated that it should be within 4 weeks. Others have changed their polymer coating to allow the drug to elute over almost 6 months. And so that's really, it's part of the technology, is in integrating pharmaceuticals into the devices that we use as well. I'll show you one other thing that we do, which is also very kind of cutting edge here. But the other things we do nowadays is, remember I said we can replace your heart valve without having to do surgery. And so right there is your aortic valve, okay? And if it doesn't work very well, it may not open. So aortic valve should open wide open to allow blood out of your heart and into the rest of your body. But over time, mostly due to senility, Dr. Slish, your valve can actually tighten up to the point where it doesn't open all the way. This is called aortic stenosis, and it's one of the most common cardiovascular conditions of aging after artery disease. And if that valve tightens up so tight, your heart has to work a tremendous amount of energy just to pump blood through a little tiny opening. You can think of this as like a garden hose. You have your normal high flow water coming through your garden hose, and then you stick your thumb over it, and you feel that hose tense up behind your hand, and then the water coming out of the end of the hose accelerates and goes really fast. Well, that's what happens with this aortic stenosis. And so you can imagine that if you take a blood pressure cuff on a 25-year-old and measure their blood pressure, the average blood pressure is 120/80. The internal blood pressure of the heart muscle, in order to pump blood through that tiny opening, can be as high as 300 millimeters of mercury. And that, of course, is not sustainable to the heart and it can fail. And so we need to fix these kind of things. And we can now do the traditional way is to open up the chest and shell out the old valve and put in a new one. But now we can do this with catheter-based things. So just like the stent, we basically have a large stent that can open up the valve. So that's basically a balloon, just like we did with the artery. We take that out, and then we put, sorry I have to do it this way. I can't do screen share because the Wi-Fi is out in this hospital. I'm on I took over one of the hospital computers, so I'm sorry for the visuals here, but hopefully this is still helpful. And then you've got a balloon that has a stent, but the stent has hand-sewn porcine valve leaflets on the inside of that stent that some manufacturer has placed in there. And as you remove the balloon, the valve immediately takes over function. The artificial valve immediately takes over inside the struts of that stent. That's a procedure we've been doing in Burlington since 2012. And this is now the dominant way most people who have aortic valve stenosis get their valves fixed. Okay, so, and I'll stop there. Does anyone have any questions about any of that?
I had a quick question. So in the video, the heart was stopped during that procedure. Is the heart actually still going during the procedure?
Yes, that's a beating heart procedure. But actually during the moment, you know what? I'm gonna open up this thing here so you can see me again now that the visuals are over. This is high tech here. It's a curtain. Okay, here we go. Okay, yeah, so what we do for that, right when, you can imagine that if the opening is only this big and you've got 300 millimeters of mercury pumping blood through that tiny opening and you got your device in there, the device is gonna, through that spew, is gonna go up and down like this. And so sometimes it's pretty hard to time when you're gonna do it because you've got a heart rate of 80 beats per minute. So what we more often do is we place a pacemaker on the inside wall of the heart, pace the heart at around 230 beats a minute, which is actually too fast for it to actually contract anymore. So it's electrically still coordinated in terms of where the electricity is going, but there's no longer muscular contraction because it's too fast. And during that cardiac standstill, physical cardiac standstill, that's when we deploy that stent across and get the leaflets out of the way. And then as soon as we see that's a good position, we deflate the balloon and then turn off the pacer and the heart resumes its normal function. So yeah, so it's it's a beating heart procedure except for that brief moment. And that moment where we place the stent valve in there is about 15 seconds. So the heart comes to a standstill for about 15 seconds just by overpacing, and then we let it come back together on its own. Okay, any other questions? Yeah, Desiree.
How long does this treatment last?
Which, what's the durability of these things?
Like
Okay.
the
Yeah, so which, the stents or the valves?
valves, yeah.
The valves. Okay, well, so you can imagine that we don't really have super long-term data if we've only started this technology 8 years ago, right? So I can say the old-fashioned way, there's two old-fashioned ways to change out a valve from surgery, right? One is a bioprosthetic valve where they take a manufactured valve but that has animal-derived tissue on the inside, either bovine or porcine leaflets. And those valves, and they're also treated at the manufacturer with certain substances to make it less immunogenic. And those artificial valves that are surgically implanted have an average lifespan of about 15 to 17 years, meaning at 15 to 17 years, about half of them have hardened up already again, and they're causing the same problem. A more permanent solution surgically, and this is how young people who have congenital valve disease, if you're 22 years old and you've got 50 years ahead of you, you don't want to go back for surgery in 20 years, right? So the other technology that the surgeons use is a mechanical valve. And so these mechanical valves are made out of polymer. They're basically hard plastic, and they usually have two leaflets that open and close. And these things are permanent devices. It's reportable if they have a mechanical failure. And I went to the manufacturer once to see how they manufacture these things. And they had a cadaveric valve. It was out of a person who died for some other reason, but had the valve in for 25 years. And imagine that there's just a simple little attachment point for the leaflet and the valve and the ring of the valve itself. The leaflet moves in here like this, and there's a ring around it. The erosion of the interface between the leaflet and the ring of that valve is only 4 microns over 25 years. So those things don't, the one drawback of that mechanical valve, unfortunately, is that you have to be on oral anticoagulation for your lifetime, which is very difficult. Imagine you're a young person, 22 years old, you want to live an active life, and then basically you should never play tackle football, check in hockey, or do anything that's going to bump your head around, because you could actually have a spontaneous bleed that could be fatal. So that's the drawback of those mechanical valves. So those are those valves. Now, our valves that we replace with catheter-based technology, the first ones were put in 2003, but in 2003, the patients they were putting in were no option surgical patients who were in their 80s. So obviously none of those patients have survived at this point. But there's some good 10-year data now. So we only started doing it in UVM in 2012. The European data goes back to the mid-aughts, and they have really good patency data from back then. So we think that these catheter-based valves are at least the equivalent of the biomechanical valves that are placed surgically, which is looking at a 15 to 17-year median life. Okay. Sorry, that's a long answer, but I thought I'd give you the whole detail.
No, thank you.
Okay. Any other questions? So that you bring that up in terms of failure of the mechanical valves and the heart valves, I'll tell you about the stents, because you probably everyone has had a relative who's had a stent, right? So there's 2 modes of failure of a stent, okay? So you imagine that, and these cartoons I showed you are not the way it looks in real life, right? So these are idealized cartoons just to demonstrate a concept, but it's really messy in there, right? So this is a biological system. And you're putting a piece of really clean metal, but before you put it in there, you're like looking at it, you're like, wow, this is really cool looking. Put it in there, and it's going into this messy system of blood and fat, and eventually it becomes scar tissue. So what you do is when we put those stents into the artery, expand. As we do that, we expand them at close to 300 pounds per square inch. Okay, so any kind of plaque, and we're not removing the plaque. Okay, we're not physically taking the plaque out of the body and putting it somewhere else. It's just moving it out of the way. But in order to do that, we have to use some force, and that pressure will cause an injury. All right, so that's a deliberate injury. We're actually dissecting the artery in order to open it up. And what happens is the most common failure for stents. The stents themselves don't degrade. They don't break or anything like that. But what happens is if you stretch out a stent of the artery, it's healing process that wants to form scar tissue. okay? And so I told this earlier with the prior to the drug-eluting stents, that scar tissue can grow through there and cause a reobstruction of the artery. That happens with modern stents less than 10% of the time. Prior to the modern stents, we're looking at 20 to 40% of the time. That's one mode of failure, and that's the most common mode of failure. The more concerning mode of failure is a clot forming on the inside of a freshly deployed stent. So when we're in there, you know, like I said, a clot likes to form on any of your equipment when you're working, because we're working in, you know, a biological system that has normal blood flow. We put that in there, and the struts of those stents are any medical device in the bloodstream is exposed to the blood itself. The blood doesn't like foreign objects. It tries to wall itself off. Generally, it tries to clot on these objects. And so most of these devices that I just talked about, the stents, the valves that you said, we have to put people on at least antiplatelet therapy and possibly antithrombotic therapy in order to prevent that clotting process on these devices we place. The stent themselves, unfortunately, if you have a clot in the stent, and especially if it's a new stent within a month, that generally causes a massive heart attack because you've got normal blood flow down the artery, the heart adapts to that normal blood flow, and all of a sudden you cut it off again. And that can cause a massive heart attack, and per event rates of mortality if you have a heart attack related to a clot in the stent is around 30%. So that's why these stents are the pharmaceutical, adjunctive pharmaceutical therapy we do for these procedures are very important, because especially that clotting of the stent, when you come out of the cath lab with the stent, you need to be on a combination of aspirin and another antiplatelet agent called a P2Y12 inhibitor. So that's the generic names are clopidogrel, ticagrelor, or prasugrel. So these are medications that inhibit the P2Y12 receptor on the outside of a platelet. What P2Y12 does is when it is triggered by something like thrombus or by ADP or something like that, it goes into it triggers a process through the G protein in the platelet to release platelet granules and cause it to be a physically active platelet that wants to stick to things. Right? So that's what P2Y12 inhibitors do. They're all a little different. The first one that they invented was clopidogrel, or the first one they invented was ticlopidine, but we no longer use that because of the side effects. But the three standard ones are clopidogrel, ticagrelor, and prasugrel. Fortunately for our patients, clopidogrel is now generic. It's been that way for about 7 years. But if you're looking at ticagrelor or prasugrel, we're looking at $300 to $400 out of pocket per month for those medications. So antiplatelet therapy is very important, and aspirin is always the core. As of now, aspirin is still a core therapy, and aspirin is a COX inhibitor and prevents platelet activation through some other ways. I'll stop there. Any questions about that class of medications? Yes, Celine.
Now, do those patients have to be on those medications for like the rest of their life as long as they have the stents in them?
Good question. So the initial technology we had for these drug-coated stents in 2003, the way that stents get their drugs on them is that the manufacturers have a polymer, and inside the polymer they embed the antiproliferative coating. And in the first generation of stents, unfortunately, the rate of clotting on those stents was actually not sky high. I mean, it was still a 1 in 300 to 1 in 1,000 proposition, but it was still high enough that that we mandated that you be on both a combination of aspirin and clopidogrel at that time in 2003 for a year after one of these stents. The reason why it's not past a year is because once that stent it elutes all its drug within the first 6 weeks or so in 2003 technology, but then once it's eluted all the drug, then your body starts to form endothelial cells on top of the stent. It walls off the stent from the exposure to the flow of blood. So your blood, when it bumps into the physical area where the stent is no longer bumping into raw metal and polymer, it's bumping into endothelial cells, and it's no longer prone to clotting. So the standard is 1 year based on first generation stents. Just last month, the FDA approved only 1 month of dual antiplatelet therapy, meaning aspirin and clopidogrel, after the implantation of the most modern of these stents. And the reason why is the manufacturers have modified that polymer so it's a lot more biocompatible. We think it wasn't really the metal that was causing a problem. It was the polymers on the first generation of stent that were the most toxic portions of the stents. And when I say toxic, a 1 in 500 prospect of some kind of toxicity related to it. Okay. Any other questions? Okay, well, so we talked about antiplatelet therapy, and there's other types of therapy, and so we also need to talk about antithrombotic therapy. So anyone know what the standard IV antithrombotic we use for any of these procedures is? All right, so your choices are bivalirudin, leparudin, or heparin. Anyone?
I'm going with
What's the
rat.
best one?
I'm going with rat poison, heparin.
Yeah. So the thing about it is heparin is the oldest of these antithrombotics. And the thing about it is we still can't prove that something is better than heparin in terms of a standalone agent for procedures that we do. For example, the amount of antithrombotic effect that we have to do while we're actively in there, changing everything inside your artery or changing a valve is actually pretty high. We measure this based on a bedside test called the ACT. Normal ACTs are less than 80 seconds, but we drive it up to around 300 seconds for all of these. So that means that within this machine, you add a little bit of some kind of caustic substance to cause a blood clot, and you time how long it takes. And you can do this at the bedside. And we go from 80 seconds to actually basically threefold prolongation of that. That's how much blood thinning we need to make sure that we don't clot inside your body while we're deploying these stents. But we haven't been able to prove that any of these new modern direct thrombin inhibitors like leparudin or bivalirudin are any better than 12 cents a vial heparin. So, and when bivalirudin first came out, it was $600 a vial. But yeah, we just can't prove that those are any better than heparin. So the standard use in most labs in America is heparin. Bivalirudin has gotten cheaper, but heparin does have some limitations. So if you read a little bit into heparin, it's completely dependent on the activity of antithrombin 3 in your body. So it doesn't directly inhibit the thrombin in your clotting system. It actually goes through antithrombin 3 to cause the antithrombotic effect. And so if you have a lot of protein binding of AT3, or you don't have a lot of AT3 around, then the heparin effect is actually diminished. That's not a very common thing, and it's not common enough for it to have affected how we conduct our procedures. But still, I guess that's what the manufacturers told everyone when they were coming out with the $600 of vial drugs a couple of years ago. But we later trials have not been able to prove that the modern ones are any different from that.
So do you test for that before you do your stent to make sure the heparin's going to work, or?
Well, if you have a problem with AT3 deficiency or protein binding for heparin, generally, that'll come out in the ACT, which is that bedside antithrombotic test we do. So we generally do standard of care is to test for an ACT before you do any of your major portions of procedure. It's also a check on other things. For example, if your IV is infiltrated on an unconscious patient and none of the heparin's getting into the bloodstream, then you're not going to get any thrombotic effect. That could be a very dangerous thing. So if you measure ACT regularly, you will know that number one, that you're getting rid of all the variability in heparin, but number two, you're making sure the heparin is getting into where it needs to go as well, especially in someone who's unconscious, cardiogenic shock, someone with a big MI. They're not aware that they're not getting the discomfort of the IV not being in place. Some of the other medications we use, as I said, we try to. So if you go back to basic principles, your clotting system basically has two components. There's the protein portion of the clotting system, as well as the platelet portion of the clotting system. So your clopidogrel, your ticagrelor, and your prasugrel inhibit the platelet portion of your system. And then your heparin, your bivalirudin inhibits, which are IV drugs, inhibit the proteinaceous portion of your clotting system. And when we're doing these procedures, generally we try to inhibit a little of both. Okay, so you want to basically tamp down on clotting in a big way during the procedure, and then in a more mild way chronically after the device is implanted for up to a year after the procedure. So the things I talked about are the antiplatelet drugs I've just talked about are all orals. And you can imagine the pharmacokinetics of those, especially in the setting of a heart attack, may be way off. You may actually give someone one of those medications, and because you also gave them morphine in the emergency room, they're not going to have any gastric emptying, and it won't even get into their bloodstream for 6 to 12 hours. And meanwhile, you've got this person right out of the ER onto your lab table, and you need that effect to happen immediately. because you're actually instrumenting the body right then and there, right? So the classic picture of this is that one of my colleagues in Paris took a picture of, during a heart attack, of the 2 pills of clopidogrel still in the stomach while he's doing his stent procedure. It hasn't moved anywhere, and the pharmacokinetics of clopidogrel is that it's a prodrug that needs to be metabolized by your liver before its active metabolite goes in. And it takes 6 hours in normal healthy volunteers for that to achieve serum levels of effect. So the question is, how do we get around that? And there are IV medications we use to inhibit platelets when necessary on the table. Generally, we use the orals, and especially in less and more stable situations, and just let those come in. Because, for example, ticagrelor and prasugrel, their serum effectiveness goes up in about an hour to 2 hours instead of the 6 or 7 hours like Plavix or like clopidogrel. But there are IV forms of these medications. And so if you look in the books, ticagrelor, which is brand name is Brilinta, was actually co-manufactured or co-developed with an IV formulation as well by AstraZeneca 30 years ago. And so their idea was you get to the procedure room, you get the IV form of the medication, and then when you finish the procedure, you transition to the oral form. These 2 forms are now separate, owned by separate manufacturers, but there is a form of ticagrelor that's called Cangrelor that is an IV medication. And like I said, if you give someone ticagrelor, put it in your mouth, and get it in their stomach, it still takes depending on gastric emptying, 2 to 6 hours for serum levels to come up. If you give someone the IV form of it, it's therapeutic in about 2 minutes. So when someone has a lot of clot in their arteries while we're trying to fix them, like for example, sometimes there's only a little clot that's blocking up the artery, like that picture I showed you. But sometimes patients with, for example, surgical bypass grafts or large arteries, they may have clot for several inches down their artery, and the entire volume of the artery is filled with clot. In that situation, you want something very powerful immediately to break up the clot as much as you can while you're doing it. We stay away from the other thing that you might be thinking of that statement might have brought up is thrombolytic therapy, the stuff that you get in the ER for a heart attack if you don't have a cath lab right next to your ER. But we tend to stay away from thrombolytic therapy in the cath lab because, unfortunately, there's a 2% risk of intracranial bleeding if you give someone thrombolytic therapy. And we're already going to break up the clot anyway with our stents and balloons. So in general, we don't use thrombolytic therapy in combination with our procedures. Some patients who live way out in the wilderness, maybe past Kenton Potsdam, maybe Messina, they're not next to the Plattsburgh cath lab, they're not next to the Burlington cath lab, but they're having a heart attack. And in those places, and this is about 70% of the United States are of the hospitals in the United States don't have a cath lab. If you're coming to a hospital that doesn't have a cath lab and you live pretty far away from a cath lab, what we also do now is we do give thrombolytics in that situation because those are going to work faster than the transport time it takes to get to the hospital with the cath lab, where you can get your arteries open physically by these devices. And so thrombolytics, that's the other category I guess we could talk about. Thrombolytics basically go in and break up clot actively. They're derived from your own tissue plasminogen activation, TPA, tissue plasminogen activator, which is a normal portion of your biology. Those have been manufactured from recombinant technology and can be given IV in a pharmaceutical dose to overwhelm any of the clotting elements and break up the clot. The problem with those are, of course, that there's a 2% risk of an intracranial bleed, which can be severely debilitating for anyone who has that. And so if you have a cath lab, in general, for the treatment of a heart attack, the patient's standard of care is to get that and avoid the risk of an intracranial bleed because we're not using thrombolytic therapy. But if you're away in the hinterlands and you're 4 hours away from a cath lab, then the standard of care is to give these clot-busting drugs, and they work about 70% of the time, so they're not 100%. They'll break up the clot enough to get blood flow down the arteries 70% of the time. But in general, the standard of care now is once that patient gets a clot-busting drug, they get sent immediately to a place like Burlington, like Plattsburgh, that has a cath lab that can pick up that last 30% of patients that haven't had opening of their artery by the medication. So again, like I said, cardiology is a fantastic field to be in. We've got the technology for the devices, but also the pharmaceuticals, and everything that I've told you today in terms of pharmaceuticals and devices. Most of our standard of care has been driven by mega randomized clinical trials. For example, the trials for clopidogrel, there have been over, the last count, 80,000 patients randomized within trials for clopidogrel. It's around 15,000 for ticagrelor, around 15 to 20,000 for prasugrel, and then probably the number of patients who've been in trials with heparin as one of the arms is probably numbering over 250,000. These devices we use, stents, treatment of heart attack, each one of these things we're talking about is based on evidence from randomized clinical trials. So that's what's fantastic about cardiology. It's a fairly common problem where you can do these massive trials pretty quickly. And also it's a fairly simple organ. All it does is pump, and with fairly simple things you can do to fix it. I mean, there's no way you can do any of the stuff to the liver, right? So it's a fairly simple organ that we have a lot of effective treatments for. And so, yeah, so it's a fantastic field to be in at this point.
Yeah, I was telling the students, we'll come back to his question in a second. I was telling the students last week, when my grandfather took a heart attack back in the early to mid 50s, the standard of care was lay in bed until you die. So it's changed a lot.
Yeah, so that's funny that you say that. So can anyone tell me what the number one cause of death for a heart attack patient was in the 1960s? Anyone? So I'll tell you how they treated him. So if you had a heart attack in the 1950s, 1960s, and the classic one here is Eisenhower, or the same analogy but with a different entity was Roosevelt with his stroke, is that the standard of care was to put the patient on the farthest bed from the nursing station, keep the lights out, don't disturb them, and let them lay there for a week and a half, okay, because they had a heart attack and they needed their rest. So does anyone know what the number one cause of death was for heart attack patients in the 50s? Strict bed rest for 2 weeks. It was actually pulmonary embolism, right? So these patients were in strict bed rest for 2 weeks. They would develop atrophy of all their muscles. They wouldn't get up at all. The nurses would do everything for them. And then they would develop clots in their legs. We didn't recognize antithrombotic or even antiplatelet therapy in the 1950s. And then they get out of bed in 2 weeks and they drop dead within the first couple of steps, because they let go of their clot that they had in their leg up to their lungs, and they pass. So that was the number one post-infarct cause of mortality in the 1950s. Modern care doesn't do that. One of the biggest increases in survival for a heart attack was the advent of critical care units in the 1960s, where you could actually see someone having a ventricular fibrillation arrest and run in there and shock them out of it quickly. So that caused mortality to go from 30% in the early 1960s to down to 18 to 15% in the 1970s. So yeah, every step in technology makes a huge difference. Any other questions? All right. Well, I hope this has been helpful. That was a lot in a little short period of time. But I'm also open to anyone who wants to observe these things in normal times. Unfortunately, I can't invite you to the cath lab during the pandemic, but if anyone would like to come and observe, it's perfectly open to that. Just have to wait till the vaccine's out.
All right, great. And we had good news about that yesterday. So we
saw that
pretty soon. So life is good. Thank you so much, Dr. Gogo. We really appreciate it.
Okay. Thank you, everybody. Thanks for having me.
See you later. Okay, I don't know about you, but I found that really exciting. He went over a lot of drugs that we didn't talk about. It would be great for me if you could write down some of those and we could talk about them next time. Because I knew more or less what he was talking about. If you were confused on some things and didn't want to ask a question, send me an email. We'll talk about it on Thursday when we get together. So Thursday we'll do that. Plus we'll do heart failure. He mentioned, he was talking about aortic stenosis, aortic valve stenosis. We'll talk about that and what the problems are with that. And also maybe even some electrophysiology if we have a chance. So that's about it. And then next Tuesday, we'll have an exam. Maybe this weekend, I'll get a practice exam up for you. Can't promise you I'll grade it, but I'll have the answers in the exam too. What else? Oh, and today I'm going to get together a Google sheet for you and some sample articles for you to look at for your presentations afterwards. So, any questions or comments? Any discussion points? No. All right, guys. Thanks a lot for coming. I hope you enjoyed it. See you Thursday.